start immediately. Right. So again, thank you very much for joining us this evening for our 1 hour into HIV lectures, particularly for the NIMART program, which is a program that teaches health workers on how to nicely and effectively manage people living with HIV and AIDS. For those who are joining us for the first time today, I am Dr. Leseho Mawela, and I'm very passionate about teaching and equally passionate about clinical care of people living with HIV and AIDS. So let us start. Just to say that this particular session and topic, we started it last week. We couldn't finish. So today we are continuing from where we left off. But what I'm going to do is to go through the first few slides, which we covered last week very quickly, just highlighting some of the things that we had discussed. And then when we get to where we left off, I will then start to go a bit slowly to ensure that you don't miss out. That is our website, aquatraining.com. So if you are interested to study with us, to study some of the programs, just visit that particular site, and then we will be able to help you as soon as you register. All right. So yes, our key focus is around managing pregnant women who are living with HIV and AIDS, who have a high viral load. So basically, it's a woman whom we would have started on ARVs, and for one reason or the other, she still has a high viral load. But this was a case we discussed last week of Maria, who is 34 years old, who presents to you for antenatal services. And this would be her first visit. On examination, you find that she is 5 weeks pregnant and she expresses some interest in counseling and testing. You do offer her counseling and testing. And there was a question which we discussed last week to say, if her screening test is positive, what do you do, right? And really the key learning point here was that, remember, we don't diagnose HIV with one test. You always need at least 2 tests. So if the screening test, the rapid screening test is positive, you want to do post-test counseling. You want to ensure that she understands what the test means and the fact that a second test needs to be done so that you can confirm her HIV status. So that is very important. And also to say that most of us, we are very passionate about HIV care. So we should not find ourselves forgetting to integrate, HIV care with antenatal care services. Remember, she is pregnant, so she needs to be assessed and she must be offered basic antenatal care services, from proper history taking around the current pregnancy, previous pregnancies, identifying risks. And if she has high risk, then we need to find ways to refer her as needed, so that is quite important. And to always say that whenever you see people, whether pregnant or not, we have to provide what we call provider initiated, where we initiate and we offer HIV testing, to everyone, particularly in pregnancy. HIV testing is very important because it can determine whether someone gets appropriate treatment or not, which is very key. So this is what you would probably do, once you get your results. Now, one of the things is that if the rapid screening test is positive, you have to do a confirmatory HIV test, right? And you can see in this instance, the confirmatory, which is the second test, came back positive, right? So now you are having 2 tests that are positive. And there's a question to say, if you have a pregnant woman who has tested for HIV and now you have confirmed that she's positive, what are some of the things that we need to be doing, right? So here are some of the things. Number one, we want to ensure that we provide basic antenatal care services, ensuring that she's not at risk in terms of her pregnancy. We want to provide her with appropriate prophylaxis therapies. This is where we use certain drugs to prevent certain opportunistic infections like your cryptococcus, TB, and also other bacterial infections like your PCP or PJP pneumonia. I'm going to cover these 3 prophylaxis therapies very shortly. You also want to take blood for a baseline CD4 count and also stage your patient using WHO staging. We want to screen her for opportunistic infections and for TB. If she does have infections, we want to treat those. And we need to ensure that she is psychosocially stable. You know, sometimes clinically, our patients are ready to be started on ARVs, but more than half the time you find that psychologically she's not ready, you know, because it's too much to take. And we need to then have ways to provide ongoing counseling to encourage disclosure so that she can get support also from home. So these are very, very important issues that you would need to do once you have a pregnant mom who's got 2 positive HIV tests. So this is very important. These are some of the things you might need to do. So in pregnancy, weight and height, but we know that BMIs are very important, but also your MOAC measurements. You want to screen for TB, you want to stage her in terms of WHO staging. In pregnancy, there's 2 ways to do a viral load. Remember, if she was already on ARVs when she falls pregnant, so she's a pregnant mom taking ARVs, then she falls pregnant whilst taking ARVs, we would do a viral load during that day when the pregnancy is diagnosed, right? However, for most women who are diagnosed for the first time to be HIV positive during a new pregnancy, right? Those women would start ARVs first, and then the viral load would be done 3 months once they have taken ARVs for 3 months, right? When we say you must stage your patients, the stage has 4 stages. It's a World Health Organization staging. And when we say stage 1, we generally talk about patients who are asymptomatic. They are not complaining. They don't have any issues. When we say stage 2, it means now the patient is starting to become sick, and most of the time they present with particular skin conditions, you know, things like herpes zoster, papular pruritic eruptions, herpes, where you find these blisters around the mouth or the genital area, and the weight loss is really just below 10%, right? And when we get to stage 3, things are starting to get a bit significant. The weight loss is now more than 10% of the body weight. You've got diarrhea for more than 1 month. You've got oral candida, oral hair leukoplakia, and pulmonary TB is a stage 3 condition. So this is very important. I'm running quickly because these are the slides we covered last week, and when we get to where we left off, I will then start to teach a bit slower. So please enjoy the ride. And then when we say WHO stage 4, we are talking about very sick patients who might be having, you know, conditions like a cryptococcus, meningitis, extrapulmonary TB, you know, pneumocystis, jirovecii pneumonia, PCP, which is the reason why we give Trimoxazole even in pregnant women to prevent some of these bad infections, right? And then also, not everyone will start ARVs same day. However, the drive is to ensure that you know, the majority of our patients who are clinically stable and psychologically ready to start ARVs, that they are started on ARVs, you know, same day that they test positive. In pregnancy, this is urgent because we have a third party, that particular child, whom we don't want, you know, for the poor child to be born with an incurable, preventable disease. So we want to fast track pregnant women and put them on ARVs as soon as possible. However, we do have pregnant women who might present very sick, maybe with TB, you know, TB meningitis, cryptococcal meningitis. You know, this is where you don't want to rush to start ARVs. You want to treat these infections first. Like if it's TB meningitis, you want to treat for at least a month, you know, and then once the TB is in control, then you start your patient on ARVs. So that is quite important for you to note. But most of the time, our patients would be started on ARVs same day that they test HIV positive, right? These are the drugs that we use. You know, we've got tenofovir. Just remember, tenofovir is one of the preferred NRTIs to be used as part of a regimen. And we would generally use it in patients who've got normal kidney function with fewer risk factors, right? One of the requirements is that the weight must be above 35 kgs. If the weight is below 35, you won't use tenofovir, you'd probably use abacavir there. And then also, you know, creatinine clearance, we don't use it in pregnancy. We rely on the creatinine level in the blood. You know, when you do your UNE, they give you urea and creatinine. We rely on the creatinine, and if the creatinine is above 85 in pregnancy, it is regarded as abnormal, right? And then zidovudine is generally preserved for second line. And then your lamivudine and emtricitabine can be used interchangeably, you know, as needed. A drug like dolutegravir, there it is now recommended to be used for all people, you know, adults, males, females, whether on family planning or not, whether pregnant or not, in all trimesters of pregnancy, and also children with a weight above 20 kgs. So dolutegravir is probably now the drug of choice to be used for all patients, irrespective of pregnancy and pregnancy duration and any fertility plans that the patients might have. We will still discuss issues of family planning with our patients, but the dolutegravir is now the drug of choice. So if you look at most pregnant women who test positive, would be initiated on tenofovir, 300 milligrams daily, right? Together with lamivudine, 300 milligrams daily. And then we add dolutegravir, 50 milligrams daily per hour. So that is the probably most, what we would initiate most stable pregnant women when we have to initiate them on ARVs. Like I said, most patients will get TLD, which is tenofovir, lamivudine, and dolutegravir. Where there are issues with tenofovir, we would then switch to abacavir, right? And in instances where dolutegravir cannot be used, we then consider efavirenz. And if both these drugs cannot be used, then we would consider lopinavir, ritonavir as an option. However, 99% of our clients will get TLD, which is tenofovir, lamivudine, and dolutegravir. So that is what most of our patients would get, right? So even though we say dolutegravir is now safe because both dolutegravir and efavirenz have similar risks and they can equally be used, you know, in pregnancy. However, dolutegravir remains superior, right? It's got fewer side effects, dolutegravir, fewer side effects, faster time to viral load suppression, which is our ultimate goal. And then there are no significant drug interactions with family planning. So really, that is our drug of choice. However, issues of family planning and integration of sexual and reproductive health services with HIV care remain very important, including involving women in the decisions that we take about their care. So we don't want women to become, you know, passive participants in their care where they are just told what to do, but they should be engaged, and we want them to actively participate. All right. So also just note that in pregnancy, we prefer to use fixed dose combinations. Remember that a fixed dose combination is not a name of a drug. No, it's not the name of a drug. We've got many fixed dose combinations. The preferred one is what we call TLD, which has tenofovir, lamivudine, and dolutegravir, right? And then sometimes we use an efavirenz-based regimen, which will be TEE, and these are some of the fixed dose combinations that you can use to reduce the number of tablets that you are giving to your patients and enhance adherence as needed. All right. So let's quickly then go into the prophylaxis therapies. There's 3 of them that you need to know about. We covered them last week. I'm just driving through, and hopefully in the next 5 minutes, we will get to where we need to get to. So the first one is called Trimoxazole prophylaxis therapy. Remember, all pregnant women generally are adults, right? They are usually older than 5 years. So the Trimoxazole is safe in pregnancy. It can be given if the mother has a CD4 count less than 200, or they have a clinical condition which allows us to stage them as stage 2, stage 3, or stage 4, right? So remember, Trimoxazole is important in pregnancy, but also for the kids when they are born. Once they turn 6 weeks old, we want to start them on Trimoxazole prophylaxis therapy. Again, we must screen women for TB, and don't forget, for women, in addition to the symptoms, we also want to collect sputum for a gene expert sputum test. So we require symptoms to be negative. We also screen them by collecting sputum for a gene expert, and if the gene expert is negative, we then check the CD4 count. If the CD4 count is below 350, we can then provide them with isoniazid prophylaxis, 300 milligrams daily for at least 12 months, right? So women who have high CD4 counts above 350, we are not going to initiate them on isoniazid preventative treatment. We will only reconsider it when they are 6 weeks post delivery. We reassess, and then we offer them the TB preventative treatment. Remember, the fluconazole prophylaxis therapy algorithm has been improved. So don't use the old algorithm, but use this new algorithm, right? In essence, what we are saying here is that if you have an HIV positive patient, whether pregnant or not, who has a CD4 count less than 100, right? We have to take blood for a Cryptococcus antigen test, what we call a crack antigen test. If that test comes back negative, then there are no issues. We just continue with ARVs without worrying, right? If the crack antigen comes back positive, this is from the blood, right? We said serum. Now we need to check whether the crypto is also in the CSF or not. So in the current new updated protocol, all patients, irrespective of symptoms, we don't even care about symptoms. If you've got an HIV positive patient who's got a positive crack antigen from the blood, they all need to be referred for a lumbar puncture. And if the lumbar puncture is positive, that means they have a meningitis. They would then be managed in the hospital. If the crack antigen in the blood was positive, you did a lumbar puncture which comes back negative, we can then treat the patient on outpatient basis by prescribing fluconazole 1,200 milligrams for 2 weeks. After 2 weeks, we reduce the dose to 800 milligrams for 2 months. After 2 months, we then reduce it again to 200 milligrams daily. This daily fluconazole must be continued for a minimum of a year, and you can only stop it when the patient's viral load is suppressed and the CD4 count is above 200. So that is very, very, very important, all right? And note that if the crack antigen is positive in the blood, we are not going to wait for the lumbar puncture results if you are unable to do it immediately in your clinic, right? The statement there allows you to start the fluconazole immediately whilst you refer your patient for a lumbar puncture to confirm whether there is a meningitis or not. So this is the key changes and improvements in that space, right? So Kabelo, you are right. The reason why we don't give INH to women with high CD4 counts is that they have bad obstetric outcomes, you know, for both the mother and the child, you know, preterm labors, intrauterine growth retardations, and so on. So we prefer to give it to women with lower CD4 counts where the benefit outweighs any risk. So that is quite important. All right. So yes, even you who are joining us via Facebook, you may ask questions. I do see your chat there. If you have questions, you may ask in between. I will try to reply, right? So if you look at it now, our patient was initiated on abacavir, lamivudine, and efavirenz, right? Abacavir, lamivudine, and efavirenz. Why abacavir? Because the baseline creatinine came back as 90, right? Remember, a creatinine above 85 is an absolute contraindication for us to initiate tenofovir in pregnancy, right? We don't do it. And then the CD4 count is 250. The gene expert was negative. So if she has no symptoms, she would qualify for INH prophylaxis, trimoxazole prophylaxis, but you wouldn't give fluconazole because a crack antigen is only done when the CD4 count is below 100. But then there's a question to say, what other assessments would you do? You know, and let me read the case because maybe I'm missing something from the case. So the case says she's back. She's now on 3 months. She's been on ARVs for 3 months. She's okay. However, she was started on TB treatment a month ago. So if you look at this regimen here, efavirenz is a good choice in terms of a TB treatment. But there's a question here to say, why was she not started on DTG? And DTG would have been the best regimen for her because in today's world, we don't want to be giving efavirenz to any patient, right? Unnecessarily. We want to be prescribing DTG. But by God's grace, she's on efavirenz. We don't need to do any dose adjustments, abacavir, because of the high creatinine. So that is very important. So in terms of assessments, make sure that you do your baseline basic antenatal care test, you know, HB, RPR, blood group, you know, all those kinds of things. Syphilis, very important because she is pregnant, right? And this table now summarizes, you know, some of the tests that you might need to do at 3 months. You know, talking to her about side effects, TB screening, adherence, asking about sexual partners, and doing your index testing. You know, and then the children also, we bring them on board. She's already pregnant. We check her weight, BMI, MOAC, WHO staging. So these are the baseline assessments. Hepatitis B must be done. A pap smear can be done, but we always prefer to do it, you know, postnatally. But I know current guidelines do say in the first trimester, you may do a pap smear. A CD4 count is done at baseline, and then at 12 months, again, only 2 CD4 counts. A viral load, forget this. This is for non-pregnant people. We will discuss it now. To say a viral load in pregnancy is done during a 3 months visit. That's why I have put a dot there. Because she's pregnant, we must do a 3 months viral load, right? And then she's on abacavir, so none of this would be done. These tests here are done if the patient is taking the particular drug, like an HB, if she started on zidovudine, creatinine, if she started on TDF, ALT if she started on nevirapine, and cholesterol if she started on lopinavir, ritonavir. Remember, she's taking abacavir, lamivudine, and efavirenz. So we don't need to do any of these bottom 4 tests, but it's a 3 months viral load that we need to do, which is very key, right? So here's the schedule for doing viral loads in pregnancy. If she's newly diagnosed to be HIV positive during the current pregnancy, you will start her on ARVs. The first viral load will be done when she's 3 months on ARVs. And now remember, in our case, she's 3 months on ARVs. So a viral load must be done, right? And then also again, if she was a woman known to be on ARVs, and then she falls pregnant whilst on ARVs, during the day when we diagnose that pregnancy, we really want to do a viral load at that point in time. So that is very, very important, right? And then Esther, you are asking, doctor, when are we taking creatinine postnatal as we are looking for serum creatinine in pregnancy? So after 6 weeks, after 6 weeks, it is presumed that women, their bodies are back to sort of the normal way. So after she has gone beyond 6 weeks postnatal, you may convert from monitoring the creatinine to a creatinine clearance like any other adult. So that would be just perfect. All right. So this particular diagram classifies 3 kinds of women, a newly initiated. So if she started on ARVs for the first time during the current pregnancy, you would start her on ARVs first, then during the 3 months visit, you then do your viral load. If this viral load is suppressed, the next viral load is done at delivery. If the delivery viral load is suppressed, the next viral load is 6 months postnatal. Then we repeat it every 6 months until the child is 2 years old. After 2 years, both the mother and the child are discharged from PMTCT, the mother to the adult program, and then the child hopefully remains negative and we are happier, right? If at the time when you diagnose the pregnancy, the mother is on ARVs, during the pregnancy diagnosis, we do a viral load. If that viral load is suppressed, we repeat it again at delivery. If it is suppressed, we do it every 6 months postnatally until 2 years. So those are the important things that we want to do. If a mother presents very late, antenatally, we then want to start her on ARVs, then do a delivery viral load, and then act on those results. That is very important. Remember, the ultimate goal of HIV care in pregnancy is to get a viral load that is suppressed. If the viral load is not suppressed, we don't become excited, we don't become happy. We want to deal with that. And some girl says, for a client on ABC, let's say the creatinine comes back normal and the patient is suppressed. Can you, yes, Samdelo, you are right. If later on, and also depending on why did she have an abnormal kidney function, if the underlying causes have been addressed and your patient is doing well, Samdelo, on Facebook, then and the viral load is suppressed, you can switch. A single drug substitution is allowed if the mother, if the patient is suppressed, right? Don't play with ARVs if the viral load is still detectable or very high. So that is very important. All right. Are you happy, Samkelo? Give me a like or something to show me that you are happy. All right. Now, remember now, she's coming in for a 3 months, thanks, Samkelo. She's coming in for a 3 months visit and she's got TB, right? So your NRTIs are Bacavir, Lamivudine. When someone has TB, you don't need to make any changes. If she was taking dolutegravir, you would have to increase the dose to 50 milligrams per Os BD. She's taking efavirenz, so efavirenz works well with TB treatment. We don't need to make any adjustments. And then also the nevirapine is a no-go area with TB treatment. If she was taking lopinavir, ritonavir, we would have 2 options, either to double the dose, right? That means, remember the standard dose is 400 over 100. So when we double, we give 800 over 200 milligrams per Os BD. And the rule is you can only double the tablets. Don't ever find yourself doubling the ritonavir, lopinavir, syrup or solution, right? Another option is to prescribe the standard dose of lopinavir, ritonavir, which is 400, 100, and super boost with ritonavir, 300 milligrams per Os BD. If you look at all these drugs, there's 2 drugs that need to be adjusted whenever a patient is taking TB treatment. These are dolutegravir and lopinavir, ritonavir. If you don't adjust them, your patient will fail treatment dismally, and it will be iatrogenic. It will be our cause, me and you. Someone says we do viral load 6 monthly postnatal until 2 years, even if the mother is not breastfeeding. Yeah. I think you have a point there, because if she's not breastfeeding, maybe it's probably, unnecessary. But PMTCT babies are followed up to 2 years. And we need to follow the guideline as is, and also because of programmatic reason. You know, the 6 months viral load is monitored, and if it's not done, it seems like the work is not done. So for now, we do it like that until they are discharged, just to make sure that there's no mixed feeding and other things at home. If you are 100% sure that there's formula feeding, by that time, the PCR would have been negative and you would have probably discharged the child from PMTCT. All right, so yeah, let's follow it as written in the guidelines, but you have a point, right? Now, at 3 months, we did a viral load for our patient, and this viral load comes back to be 10,000. I think this is where, you know, the issues are. So you have one viral load, which is 10,000. You know, what do you want to do? And then Tandega says, Dr. Mawela, if a woman on IPT falls pregnant during pregnancy with a CD4 count greater than 350, Tandega, you should stop the IPT and review it after she has delivered, right? The risk is too high with women with high CD4 counts. So we keep it like that. Tandega, I hope you are happy with my answer. You stop it, you deal with the pregnancy. When she's 6 weeks after pregnancy, you may reassess her for IPT. All right, yeah. Unfortunately, we'll have to stop at that point in time. So tell me, you may type in your answer in the chat box there. What do you want to do for Maria, you know, at this point in time? What do you want to do? You know, I was going to share my questions. I don't see them. I don't know what happened to my multiple choice, but it's okay. So when you have one high viral load, right, your key goal is going to be one, adherence support for the mother, discussing with her what problems is she experiencing, you know. So let's look at this. This is a snapshot from the guidelines, from the PMTCT guidelines. It's an algorithm. It's called viral load non-suppression, right? That means it's an algorithm you use when you have people or mothers with high viral loads, right? So, and it says there, if the non-suppressed viral load is more than 50, and in our instance, the viral load is 10,000, there's a red. You see those red dots. They say you must do A, B, C, D, E. We've got only one high viral load, right? So adherence, we are checking for side effects. Is she mentally okay? Is she able to take care of herself? You know, there's issues of alcohol and substances, poor social support. We encourage disclosure. We check for infections B, you know, bugs, infections. Is she taking the drugs correctly as prescribed? You know, are there any drug-drug interactions? And if she's taking drugs where resistance testing is indicated, we might need to do a resistance test, you know, at that point in time. Dikeledi, I see your question there to say a newly diagnosed HIV positive pregnant women, we initiate on TLD. Yes. TLD all the way. It is now safe in pregnancy. And in this way, you are right. If at this point she's got a viral load of 10,000, so you would do enhanced adherence counseling. And what is that? It is this A, B, C, D, E that I have showed you. Offer index, yes, if she's got a high viral load, she's got a sexual partner, maybe the partner might be infected. Repeat the viral load after 1 month. Yes, in this way, we are kitchen, we bambile. I'm happy with that, you know. So if the mother, what happens if the patient is a known positive but never on ART? You start her on ARVs. And you also assess why she was not on ARVs in the first place. But looking at going back to our scenario, we've got the first high viral load, which is 10,000. What do you do at this point? You don't change any drug. You don't switch efavirenz and give dolutegravir, right? Because the viral load is 10,000. When the viral load is high, we don't play with the drugs. We want to check first, what is it that is happening? And this is the A, B, C, D, E that we will be doing at this point in time. And then you support this pregnant mom for 30 days. After 30 days, as you can see there, after 4 to 6 weeks, we repeat the viral load, right? After doing A, B, C, D, E, the first viral load was 10,000. We do A, B, C, D, E, and then we repeat the viral load, and we will decide when we get that result for the second viral load. So it's important that you know how to address a high viral load. You must also be supportive. You must not be judgmental, because women go through a lot. Also try to use some of the tools like pill counts, because most of the time, a high viral load reflects a poor adherence, which is very important, Yes, Sarah, I'm happy with that, intense counseling so that she understands the risk to the baby, the risk to herself. She might start to become sick if her CD4 count drops, but also the risk of infecting other people like sexual partners. But also sometimes it's not her own doing. You must review the treatment and check whether she's taking it correctly, whether it was prescribed correctly, whether there's things that me and you would have missed, at that point in time, which we need to correct. So there are simple things that you can do, like plotting on a graph the viral load and CD4 count, so that you are also able to show her how things are going, checking the prescriptions for the correct drugs, checking if she understands the dosing, look at other factors. Some people crash tablets that are not supposed to be crashed. Some people are taking treatment holidays over weekends. They don't take their drugs. If she has not disclosed, it means she has no support. Then there's clinical factors, like maybe she has previously been on ARVs. Maybe you were not aware and maybe she failed, like your PrEP patients. If someone fails PrEP, most of the time they also need to get a resistance test before we give them, another regimen to see if there's resistance or not. Maybe she's having diarrhea, she's failing to absorb. So social factors, stigma, violence at home, lack of food. So you have to take a very comprehensive assessment. Don't take it lightly, if you really want to get most of your patients to resuppress. I've just put these two graphs without complicating, the whole thing for you at this point in time. But just to say that at different viral load levels, you see that mothers who are likely to infect, their infants. And most of the time, if the viral load is less than 1,000, the risk of transmission is not zero, but the risk of transmission is very, very, very minimized. So we don't want to smell, we don't want to detect any viral load in pregnancy. If the viral load is high in pregnancy, we want to deal with it urgently. Otherwise, we're going to end up with a child living with a disease that we could have prevented. So this is very important and key. Again, if you look at viral loads below 1,000, you can see that even a viral load, which is below 1,000 but still detectable, is a problem in pregnancy. There's still a risk of transmitting, though the risk is lower, but we don't want to smell or see a viral load in pregnancy. So that is quite important in our instance, right? So here we are. Unfortunately, Maria had problems, so she never came back to review the viral load, the second viral load. Remember, she came in with a viral load of 10,000. We did enhanced adherence support. We repeated the viral load. Either we didn't track her, we didn't trace, or she didn't come back. But anyway, she last disappeared when we drew the viral load. And now she is back. And she's got a baby now, Tepo, who was even born at home. Probably Tepo is unbooked, I suspect, which is now a problem. The last viral load, which we repeated antenatally, was 3,000. So, there was some improvement there, which we should appreciate in a way. There was more than one log drop. You see, 10,000 has 4 zeros, right? 3,000 has 3 zeros. So you lost a 1/10 there. So this reduction antenatally was significant, but this is a long time ago. And considering that she seems to be unbooked, she delivered at home, and she disappeared, we can't even trust that viral load, right? We need to then look at the other things so what do you want to do? Can you type for me in your chat box, live chat? I see, Sarah, you are saying you want to do a post-delivery. Yeah, you have even given it a name, post-delivery, because we couldn't do a delivery viral load. So now we do a post-delivery viral load. Esther says a baby PCR. Yes, Esther, a birth PCR. Glaciers, we must do a birth PCR for the infant. What else? What else? Hey, tell me more. What more do you want to do? I mean, she delivered at home. You want to stabilize her. You want to check the child for any injuries. You want to make sure that the PPH and all those obstetric things are sorted. Let's not forget those things. But then in terms of PMTCT, you've got the mother and then you've got the child. So for the mother is to do the viral load, check if she defaulted or if she was still on ARVs, then maybe you would want to continue to give her, you know, her ARVs as needed. The child, is the child low risk or high risk? Sindisi, where are you guys? Nituli, lady. I see Mafezi, you are saying birth PCR. Yes, I want more. Rebecca, Masiete, Gugu. I want more. I see high risk. Yes, Sibonison Tabi saying high risk. And if you say high risk every time, not sometimes, always, when you see a high risk, yes, I see, and Google, I see there. Just remember, every time you say high risk, two things need to happen. Need to ensure that the mother is supported to start or to suppress as soon as yesterday. Every time you say high risk, the child must be, a PCR must be done, and the appropriate prophylaxis must be given, dual prophylaxis, which is a combination of zidovudine and nevirapine. The zidovudine being given for 6 weeks, like Esther is saying there, and then the nevirapine for 12 weeks. This is very, very, very important. One delay, Busugu, the child is high risk. Yes, you are right. Gugu, I'm happy with dual therapy, as you are saying there. So I'm happy with all the explanations that have been given. So let's just look at the theory there. You know, so a viral load is very important. It is the preferred patient monitoring. When we deal with hypertensive patients, right, we say a BP is what we are measuring. When we deal with diabetics, we check, you know, your blood sugar or A1C. You know, in HIV, it is the viral load that will tell us if things are going well, right? So in this instance, you see that the viral load, if it is measured twice, so treatment failure, virological treatment failure, when you have a viral load that is more than 1,000 on 2 consecutive occasions, 1 month apart. So our patient really, she had failed antenatally. Unfortunately, she disappeared, even though there was some, you know, significant improvement. If you look at the logs, I suspect that she has probably failed, especially because she's taking an efavirenz-based regimen. If she has defaulted, like I'm suspecting now, I think she has failed. And Rebecca, she's saying, yes, doctor, let's do a PCR and nevirapine, let's do the viral load, you know, yeah. And then Ruth, I'm seeing your question. I can only answer it after here because we are dealing with pregnancy today. All right, so very, very key. Glaciers is saying, also, if the mother is breastfeeding, if so, then give nevirapine for 12 weeks, and then 4 weeks post cessation of breastfeeds, then AZT for 6 weeks. Okay, I'm sure you, when you say cessation of breastfeeds, I'm suspecting you wanted to talk about PCR, because the PCR would be done 6 weeks after cessation of breastfeeds, right? Lufuno, switch to second line regimen. It's a possibility. The problem is we don't have evidence, you know. If she defaulted, you would want to restart her on her old regimen, then do the viral load after a month. If she's not suppressed, then probably consider her as someone who has failed. So it's a bit complex in that instance to say, do we start her on her old regimen? Do we give her a second line regimen? I mean, hopefully, remember, you know, if yeah, you know, she would need yeah, so it's a very difficult one. We need to then just follow the guidelines. If we follow the guidelines, We need 2 viral loads taken 1 month apart, more than 1,000. We don't have this. Remember the previous viral load, there was a 1 drug lob. So we don't have strong evidence that she has failed. So one has to give her the benefit of the doubt. If she has defaulted, restart her on the same regimen, then repeat the viral load after a month. If the viral load has not suppressed, that's when you can then say, I'm switching her to second line. Remember, she's taking an efavirenz based regimen. Tandega, I'm seeing that. Thank you. She's taking an efavirenz based regimen. She's got the 2 viral loads that are high. We are considering switching her to second line. So once you have confirmed treatment failure, if let's say she fails to suppress, you would give her a dolutegravir based regimen, right? Hopefully, you know, there are no contraindications to DTG. Then she takes it. If there's problems with DTG, then lopinavir, ritonavir becomes the drug that you are going to give. So if you look at it now, she's taking abacavir, not TDF. She's taking abacavir, lamivudine, and efavirenz. If you have confirmed treatment failure, we check the hepatitis B status. The baseline one was negative. So if you were to switch her, you would give her zidovudine, lamivudine, and dolutegravir. So Lufuno, once you have confirmed treatment failure for our patient, right, that's when you would then stop abacavir, lamivudine, and efavirenz. That is what she's currently taking. And then you would give her zidovudine 300 milligrams BD, lamivudine 300 milligrams daily, dolutegravir 50 milligrams per hour daily. Remember, at 3 months in her pregnancy, she had TB, right? Don't ever forget that. So we don't know whether she defaulted, whether she completed her TB treatment. If she has completed TB treatment, your dose for dolutegravir would remain 50 milligrams daily. If she's still on TB treatment, then you would have to increase, particularly if she's still on rifampicin, you would have to increase that particular dosage to 50 milligrams 12 hourly or BD. So under TB, it will be zidovudine 300 milligrams BD, lamivudine 300 milligrams daily, dolutegravir 50 milligrams twice a day or 12 hours. So that would be how you approach this particular case. Don't forget, you know, to always, when you look at mothers, you know, routine care, whenever you see a mother, whether suppressed or not, you must reinforce adherence, you know, monitor the mother, you know, in terms of the viral loads that need to be done. If it's postnatal, like I said, every 6 months, you know, TB screening, support infant feeding, particularly breastfeeding is best. You know, check if she needs a family planning options, a pap smear, you know, nutritional assessment, and ensure that she's supported, you know, as needed. Now, going back to the case, remember now, Tsepo is born. Tsepo is born, right? The baby is born. What do you do for the child? We have already discussed some of the things you would do, but let's look at the PMTCT has 2 strategies. Number 1, we need to quickly get Maria to be suppressed, right? But whilst we deal with Maria's issues, we need to protect the child. How do you protect the child? You provide the child with infant prophylaxis, and you need to be able to provide the appropriate prophylaxis, and I will cover that now. Don't forget that when the child turns 6 weeks, we must start the child on Trimoxazole preventative therapy, and we must start the child on ARVs only if we have done a PCR and the PCR is positive. Please don't start HIV exposed infants on ARVs. You need to have a confirmed HIV status for you to start any child on ARV. Sometimes we make those mistakes, so let's not make such mistakes, right? So for the child, it's the prophylaxis, it is the Trimoxazole. We promote breastfeeding, and we always want to assess normal growth and development. You know, the milestones, your plotting of the weight of the child on the graph, those things are very, very crucial and important. I asked about this child to say, is the child low risk or high risk, right? We agree that the child is high risk. Why? Because the mother disappeared, the mother defaulted, the mother delivered at home. We have no evidence that the mother is suppressed. The last viral load that was done antenatally was high. And the principle is to treat all babies as high risk until you have evidence that they are low risk. Please don't forget that. So if a child is born today, you give them nevirapine and AZT. And then if your viral load comes back suppressed, you can always stop, the AZT. And the difference between low risk and high risk is that if the child, there's evidence of a viral load that's suppressed from a mother who's reliable, you can just give the child nevirapine for 6 weeks, nevirapine only for 6 weeks. But where we suspect that things are not going well, the child will get nevirapine for 12 weeks. So it's extended. The nevirapine is extended and the zidovudine is taken for 6 weeks. So those are the important things that are very important. So anytime you have no evidence of virological suppression, mother diagnosed for the first time in labor, diagnosed for the first time during breastfeeding, started ARVs last week, she delivers today, those mothers are high risk, all of them, and then we take it from there. Someone is asking, do we initiate TEPO on INH? It's a very important question around how you prevent TB. So firstly, you'll need to take proper history, whether the mother has completed TB treatment or not. Probably she has completed, by God's grace. If she has not, she needs to be restarted. Then we need to investigate the child. The child will probably need TB treatment if the child has symptoms or even the Montauk's test is positive, right? How old should the mother's viral load be for you to identify low risk or high risk? Siboniso, the delivery viral load is the decider. The delivery viral load. So you're going to do a delivery viral load, you wait for the result. So whilst you are waiting, that child is high risk, right? But if she had a viral load done last week, there's no need to repeat a delivery viral load, isn't it? We don't want necessarily to waste, but the principle is you want a very recent viral load, less than a month, if at all possible, Anything more than a month, you probably should wait for your delivery viral load. Then you make that particular decision right there, right? I hope you are all still with me. So again, if you look at this algorithm from the guidelines, it's got green and the reds, and it's got the mom and the child. It says here, if you classify both the mother and the child as low risk, you need to continue to support the mother. We are talking about the mother whose delivery viral, you see, the decider is a delivery viral load. So if the delivery viral load is suppressed, you do a birth PCR and then you continue nevirapine for 6 weeks. If the delivery viral load is high, or there's a recent viral load that's high, or you have no viral load results, you treat both them as high risk. You work on resuppressing the mother. You protect the child by giving the child dual prophylaxis, which is nevirapine and zidovudine, and then you do that birth PCR. Remember, the Trimoxazole in purple there will be started at 6 weeks. Don't start it earlier. As per the protocols. So that is quite important, right? This is the dosing. We won't go into the dosing of, you dose by weight, isn't it? Based on the weight of the child, you then dose it as needed. Trimoxazole, we started from 6 weeks. So that is very important. Just remember, in terms of testing, as we summarize today's session, a birth PCR is mandatory for all babies born from a mother who is HIV positive. So we call them HIV exposed infants. All of them must get a birth PCR. If it's negative, it's followed by a 10-week PCR. If it's negative, we do it again at 6 weeks, right? And if the 6 weeks PCR is negative, we do a rapid test at 18 months, right? And then we do the final test again when the child is 2 years old, right? And there's 2 other additional tests. Number one, which is very important to me, is that please make sure that if you have let's say you have a child who is 4 weeks old and the child is brought to you, the child is not doing well, please don't say, the child is not well, I'm going to wait for 10 weeks. No, anytime you have a child who's sick, who's not doing well, you must test the child. So that is very important, and it's there. An age-appropriate test anytime the child is symptomatic. That is very important, right? And then also 6 weeks after cessation of breastfeeds. So if a mother says, I'm going to breastfeed for a year, and today it's a year, they are stopping to breastfeed, you count 6 weeks from that time, and then you will do another PCR 6 weeks after the breastfeeds have been stopped. So these are very important tests. For our case scenario, we'll do a PCR today. Even if the child was born at home, we do a PCR. If it's positive, we want to confirm it and start ARVs. If it's negative, we repeat it in 10 weeks, then 6 months, 18 months, and then until 24 months, we continue to test the child. Kabelo is asking, with the new guidelines, if you have a pregnant mom on TLD with 2 consecutive viral loads, when does one switch her? Kabelo, let's park that one. I'm gonna I'm gonna come back to that. It takes 6 months. Oh yeah, so the PCRs is 10, it's birth, 10 weeks, 6 months, and then you do a rapid test at 18 months, and then you do another rapid test at 2 years. Says Nomsa, do tell me if I'm correct on that one. Yes. Now, where are we now? So in addition, we don't just, our worry is not just the PCRs and I can tell you, babies who are HIV exposed have a higher risk, of not doing well and even dying and admissions, even if they are negative. But because, half the time their mothers are not well, sometimes, the mother is also not there, they've passed on, some of them are orphans. There's a whole lot of things about what we call HIV exposed infants. So please don't just focus on the PCR and the prophylaxis. Always assess these kids, about feeding, what are they being fed, encourage breastfeeding. You have to continuously check them for infections. Are they growing well in height? Is the head circumference, growing? These are very important things, because you could still keep the child negative, but you keep a child who is not healthy. We want healthy children who are going to grow, who are going to be strong, and who are going to be well. So they are at risk of not growing well, risk of anemia, hospitalizations, and even death. So please remember that. So that's why even those who are doing NIMART, they know I'm very strict. If you don't tell me that you're going to check growth, you're going to check development, you're going to check that the immunizations are up to scratch, you're going to check feeding and how the child is doing at school, I'm not happy, because you are now becoming an HIV super expert. You must be comprehensive in your approach. And I encourage you to also use IMCI in terms of managing your kids and ensuring that you don't miss important things, right? So Trimoxazole for children, we started when the kids are 6 weeks old. It is continued for as long as the child is being breastfed. You'll only stop Trimoxazole the day you have a negative PCR in your hand. You say the final PCR. So if the child was being breastfed, you do a 6 weeks PCR, you wait for that 6 weeks PCR. If that result comes back negative, then you can consider stopping Trimoxazole. So always monitor their growth and development, encourage mothers to breastfeed. If they're using formula, support them on how to prepare it safely. If you do a PCR, track the results, and if the results are positive, you need to act on them. If they're negative, we encourage the mother baby pair to keep the child like that. And we need to ensure that the immunizations are always up to date. These are soft things that if we don't get right, would affect our kids significantly. In summarizing this session, when you see a high viral load, right, you have to do enhanced adherence counseling. Very important. You have to follow up mothers who are pregnant with high viral loads during that 30 days and repeat the viral loads, act early. If the viral load is high, you need to act early, right? Remember, if the viral load is high, you don't play with drugs. Don't just say, I'm going to stop efavirenz and give DTG. No, you need to confirm if the mother is failing by correcting your second viral load. If you have confirmed treatment failure, they need a new regimen. They don't need you to play with one drug. I stop this one, I start that one. You're going to create a lot of problems, right? And lastly, do a single drug substitution when the viral load is suppressed. So if a patient has a suppressed viral load, they are taking tenofovir and they have a high creatinine, you are allowed, at that point in time to say, well, the viral load is suppressed, I can stop tenofovir and give abacavir. But if the viral load is detectable, it is high, don't play with the drugs. You're only going to cause more harm to your patient. All right. Yeah. So remember, if you see the mother, ask about the child. So if any mother, if you see my wife today, if you see her, you must ask where the children. If you see a child, ask where's the mother, all the time. And that is how you're supposed to manage it. So Kabelo is asking there, with the new guidelines, if I have a patient so let me show you, and we will do a very complex topic. I like it when you ask questions because they give me ideas around topics that you can deal with. So next week we can do a topic on patients who are failing a DTG or lopinavir and how to approach them. I have a nice set of slides that cover that, right? But from the guideline, you will see if she was taking dolutegravir, we would need at least 3 consecutive viral loads, that are high. But the algorithm is more complex than this. So I don't want to answer you, Kabelo, today. I'll probably confuse everyone. Let me prepare that for you next week. Don't miss it, KB. And then I'm going to take you through how you approach patients who are failing a dolutegravir-based regimen. It's not as easy as you see it here. And then let's deal with it properly. All right. So yeah, so thank you very much. I hope it was a great session. Those who are joining us, via Facebook, thank you very much. I hope you guys have enjoyed the session, but importantly, those who continue to join us, on a weekly basis, via your Zoom, spending your data. I'm hoping that you are benefiting from these sessions. But before you leave, there's a program coordinator here, PMTCT, says Nomsa. I want to give her a chance to just raise highlights. I know there's always gaps in the facilities that she wants to emphasize. Says Nomsa, do you have anything that you want to emphasize, issues of codes and stuff? That would be great.
Yes, thank you, Pudi, for the opportunity, and good evening, all colleagues. I just want to emphasize the issue of putting an EGK code whenever you're doing a viral load for a pregnant woman or a breastfeeding woman. For women who are still pregnant,
Says Nomsa, please unmute again. Says Nomsa, unmute. I think we have lost her. She was going to tell us about the codes
to be processed, because if you don't put the code, they won't process the specimen.
Says Nomsa, can you start again? Which code must we put where? Thank you.
Okay, we're using the N1 lab requisition form. Please make sure you get.
Oh, what's going on? Says Nomsa, network yakho yasilahla. What happened? Okay, let's try again.
And then when the mother is in labor or has just delivered, you write C #delivery so that it shows that it's a delivery viral load. Because if there's no EGK code, they are going to reject the specimen. Remember, we said that you need to make a decision based on the mother's viral load. So if the viral load is older than 3 months, you must repeat it at delivery. So if maybe, for example, was done a month ago, now you are doing it again, they are going to reject it if there's no code. But for all our PMTCT viral loads, for them not to be rejected, we need to put the code, which is important. And then again, the issue of Trimoxazole, Dr. Mawela, we stopped the Trimoxazole 6 weeks post cessation of breastfeeding, provided the baby has been done a PCR and it is negative. As long as the child is still breastfeeding, we continue the COTRI using the dosing chart per weight until the mother stops breastfeeding. 6 weeks later, you do a PCR and it's negative, then you stop. Thank you.
All right. Thank you. Thank you very much, everyone. Please do share with your colleagues. Give us a lot of likes there on Facebook to show that you enjoyed the session. Share it with your friends. And then, yeah, we just want to continue to improve, our performance and ensure that we have no babies born with HIV. It's very possible. We have seen them, and that is our contribution in our lifetime. Okay, thank you very much. Keep well and keep safe, and may the good Lord richly bless you. Thank you.